everybody, and welcome to another episode of the Open Forum podcast. Today we have with us Dr. Stephen Templeton. Dr. Templeton is a PhD from the University of Indiana, an associate professor there within microbiology and immunology, and having also previously worked at the CDC and the NIOSH. Dr. Templeton, that's a very brief 20-second introduction. Why don't you take a couple minutes to introduce yourself, and then we're just going to dive on in.
Yeah, so I started off really interested in immunology, wanted to be an immunologist since I had been an undergraduate. I was introduced to the topic itself. I thought it was a beautiful subject, wanted to know more about it. And so I went to graduate school and ended up studying viral immunology, interestingly, a coronavirus. And then after graduate school, I went on to CDC NIOSH, which is the Occupational Safety and Health arm of CDC research. That was in West Virginia. I spent there for about 4 years. Then I came here in 2011, been here for over 10 years, studying infectious disease models, particularly in immune-compromised individuals like fungal infection. That's what I've mainly focused on. And then since the pandemic has started, I've been really interested in thinking about the pandemic response itself and the fear that was evident in response to the pandemic. I started out thinking in a local sense, trying to kind of reassure people that the worst case scenario probably wasn't going to happen. And then it began to get sort of bigger and bigger on a nationwide and now on an international scale. So, I didn't really know how this was going to shake out when I first began to speak out, but this is where I'm at.
Enough.
On your podcast.
Yeah, that brings us to here today. I think what you mentioned there about getting involved at the local level, you're also involved on the local school board, right? Or local district with regards to the COVID pandemic response there, right?
Yeah, so it's just an advisory board. And I was actually asked to be on it because I think the superintendent actually wanted a contrarian.
That's good.
And I might be the only one. That's what it seems like, but I think it's useful to have somebody who's willing to challenge what's being said.
To look at things from the other side, which it's funny, the superintendent feels that way, and yet on the national and international scale of things, there doesn't seem to be a lot of want for dissenting voices almost.
Well, they have to deal with the political side of it.
True.
It's some of the things the experience that I have, but yet, I'm within 6 degrees separation of a lot of these interesting things. I studied coronavirus immunology, but I don't do it right now. I work for CDC NIOSH, but I don't do that now. I'm an immunologist, but I don't study vaccines right now. And so having a connection to these things, but not having your career depend on the sort of group pressure that you might be thinking or experiencing, whether it's real or imagined, allows me to be a little bit more open in criticizing things, I think. Because, when you hear from people who are in positions of leadership and public positions, they're concerned about everyone's perception, and that's something I wrote about in my last Substack article. And they need to be seen at sort of addressing that perception. And if the public is way off and they're reality, then the leaders are going to reflect that whether they want to or not. I mean, that's kind of, unfortunately, politicians and leaders' jobs is that they don't see it as standing up to the public. They see it as serving the public and sort of continuing their own interests.
Yeah, no, absolutely. And I think that's a key point you raise. It's their own interests rather than that of the public, which is kind of funny considering their position there is as a result of the public that they're supposed to be serving and looking at their ideals. But let's come back to the main crux of why we're here today. Let's come back to immunology, your wheelhouse. And is there, straight off the bat, let's go for the big question that most people want to hear, most people want to hear answered. Natural immunity. Initially, we were told it was only good for 3 months, yet we have decades and decades of research over what natural immunity is. We've got things like cross immunity as well from previous infections. Is there anything to worry about for people who have developed natural immunity as a result of being face to face with coronavirus, COVID-19, and having had infection?
Yeah, everybody has, I mean, that's, you have to give a nuanced answer to that, right?
It's
I
a
mean,
loaded question.
Yeah. So, I mean, everybody has a different immune response. Everybody has a different history of what coronaviruses they've been infected with. Everybody has a different capability and of their immune system, depending on what drugs they take, depending on their overall health, whether they're obese or have some other inflammatory disease. So it's really, generally, I can say that immunity to infection does provide a lot of protection from severe disease in, upon a reinfection. And some of the comparisons between natural immunity, which some immunologists don't even like that term, so I try to use the term infection-acquired immunity.
Okay, I'll do my best to use that.
Not that there'll be a lot of immunologists listening, but I try to be consistent. But anyway, some of the nuance I think has been lost when comparing the vaccine-induced immunity to infection-induced immunity or acquired immunity, because they just would say, is this better or is it worse? Is it longer lasting? I mean, there's a lot of different aspects to that. One of the things that claims that have been made when people say, well, vaccine-induced immunity, acquired immunity is better, is they're just talking about antibody levels. And what's that been shown is that they peak at a much higher level than many people who have acquired infection immunity. They're only talking about antibody levels, and then they drop eventually. Both of them drop, but you also have the other arm of the immune system, which is your cellular immunity, and these are cells that recognize infected cells and kill them, called T cells. There are other cells, types of T cells that help other immune cells with their function. Right? And those helper cells also are quite long-lasting, and they only take 2 or 3 days to get ramped up, and antibodies can get made pretty quickly. So when you're talking about better or worse, there's a lot of nuance in there that gets lost. I mean, are you talking about preventing infection completely, or just preventing severe disease? I can say, infection-acquired immunity is generally very, very robust for most people.
Yeah, I think one of the things I want to latch onto there before digging too deep into the different levels of the immunity is just on the antibody response or the amount of antibodies that are there. That is being touted as the way to measure your ability to fight infection. But in reality, that's not the only thing that matters, right? And that's kind of what you were saying there as well, that the amount of antibody present in someone on testing, whatever, if you're going to do a rapid test or something, which is going to show your antibody level, that's not the optimal measure. If there was someone talking to you as an immunologist and they said, yeah, I've got X amount of antibodies per millimole, what have you, what would your response be to that?
That they had a basic lab test for their antibodies, whether it's specific or not. I mean, the different assays have probably different sensitivity, and if they're just measuring, and this is part of the nuance, if they're just measuring antibodies against coronavirus, you don't know whether they're neutralizing antibodies or what exactly their function is. So there are a lot of different types of antibodies. Generally, if you have a natural or infection-acquired immunity and you have antibodies, there are going to be some there that are protective. But there is some obvious nuance in there. If somebody had a really rough infection, had a lot of inflammation, was hospitalized, some of those antibodies could be pathological and actually cause more severe disease.
Upon reinfection, you mean?
Yeah.
Yeah. And are you then referring to sort of ADE there a little bit? Antibody dependent enhancement kind of thing there?
Yes, that can happen in some people, certainly.
Can you maybe expand a little bit more there for us?
Yeah, so I mean, if it's not clearing the virus and there's a lot of virus there, it can, cause some collateral damage in the tissues where the virus is. The antibody can, bind to things that aren't virus, or it does it in a sort of an incomplete way. It's not necessarily enhancing the infection, although there are some viral infections that can happen, but it could be enhancing the disease itself, and that's the inflammation, which is really, and people who have severe disease with COVID-19 are getting this collateral damage from the immune system, not necessarily from the virus itself.
So from the immune system being a little bit too ramped up, the immune system being a little bit hyperactive, shall we say?
Right. It either, one way to explain it would be it gets behind in the early innate immune system, and then it overcompensates, and has a very destructive response that ends up, harming lung function and potentially killing the individual.
Okay. And this is a function of our immune system then. So what is it that we can do preventatively to try to mitigate these kinds of risks, these kinds of issues? Is there anything that we can do at point of infection or point of realization that there's something going on?
Yeah, well, I would say in a really broad sense to just live healthy lifestyle, because the people that have lots of comorbidities, some obviously are ones that individuals don't have control over, but some of them more control than others. So each individual should just live as healthy as they can, and that's sort of the big picture. There are probably some genetic determinants that may make things worse for certain people, because some families have shown to, have more serious disease. It's not entirely clear what those are, as far as I know. I've seen some papers, but nothing really stood out from that. So obviously, that would be something people wouldn't really have control over. These immune responses are trade-offs. If you have a really strong immune response, you're going to have some damage, but you also can be, really protected from a future infection. and a longer lasting antibody response that could limit a reinfection. So every immune response does have a trade-off. Sometimes people get an autoimmune disease after they've had an infection, or after they've had a vaccination. So immune responses are very well evolved to deal with these things, but they're not perfect. You get a billion people infected with the same virus, you're going to have an awful lot of different responses to study. It's going to take a long time to sort it all out.
Absolutely, yeah. And then, so I suppose one of the things that I was leaning towards when asking you how can we mitigate it, you've quite rightly said lifestyle factors are a big aspect in this. Yeah, a lot of research has come out to say that comorbidities such as obesity or previous underlying heart conditions or things like that can have a massive influence on the severity of disease that you may or may not acquire. So I think what I was leaning towards there was, is there any kind of pharmaceutical intervention that we could potentially use? And where I was going to lean on that is there has been some work, or not so much some work, there have been some people that said that if you're going to use any other type of pharmaceutical drug, if we say fluvoxamine has recently been shown to have quite a positive effect, then you may as well just get vaccinated, because you're doing the exact same thing as what you'd be doing with the vaccination. Does it have any modifying effects to your immune response if you are to use any other kind of drugs during your infection period? Would it prevent you from developing a full, robust immune response? I suppose is the question that I'm trying to get at here.
I suppose potentially yes, but by the time you know that you're infected and you get to the point where you're taking one of these pharmaceutical interventions, the course of an immune response in terms of how much memory is there after you've recovered. I mean, a lot of that is kind of already been taken care of, so you're starting to see the bad effects of immune response. You're not really interfering with it unless you started taking it before you got infected, because that's where those first inflammatory signals would really make a difference. And actually, if you would interfered with that, you might prevent the early immune response and prevent some formation of memory maybe later on. But yeah, I mean, it's going to be, like I said, it's a trade-off. You want to knock out the immune system in a later stage. That's if you're suffering this collateral damage. Yeah. I would say, this sort of just automatically taking some of these drugs, if you're not in a high risk group. I mean, just me personally, I would be interested in doing anything other than just taking care of myself and getting through it. I'm 47, so I'm kind of on the
getting close to
not really in high risk, but I kind of
not yet
on the cusp there.
Yeah, not yet. Okay, and then I suppose that kind of brings us sort of neatly towards the vaccine-induced response, and this is something that you've written about, the comparison between both naturally acquired immunity, infection-acquired immunity, versus vaccine-acquired immunity. What, if any, difference is there that we're likely to be seeing in the immune response between these two ways of going about it, shall we say?
Yeah, we have different types of vaccines, and the one that is most widely used, two are the Moderna and Pfizer, and those are the ones I use, at least in my Substack article. It's not a live virus; it's just simply a encoded mRNA, the spike protein that enters cells because it's packaged in a way that will allow the cells to take it up and translate those mRNAs into spike protein that then get assembled in a way that looks like those cells are infected to the immune system. It induces them to basically, mount a response in that area at least. Now there are some, spike proteins that migrate around. I realize, they get to the lymph nodes or other parts of the body, but the initial response is much in the area where there's the injection in your arm, the muscle cells of your arm. And in an infection, you're actually getting infected in your airway cells, which are mucosal cells. They're a different type of cells than the cells that are in your arm. And they have a different type of an immune response there, because in your airways, you're breathing in things all the time. You're breathing in bacteria and fungi and viruses, and you're not really mounting strong responses to all of those things. Hopefully, if you're a healthy person, your immune system's ignoring a good chunk of that junk and just clearing it out and not really doing anything with it. So you have mucus that's being secreted and things like that are keeping out pathogens. You don't have that in your skin and your muscle, and so where the immune response occurs really does make a difference in how a memory response is induced and maintained. So actually having an infection in your airways puts cells in closer proximity to those airways that are memory cells, that if there is a reinfection, those cells remember where to go. They remember to go to your airways, your lungs, and that doesn't happen in a vaccine that's just injected into your arm. They don't get those signals. You have those cells there. They will eventually find their way to the lung if you have an infection. That does prevent severe disease, and that's been shown, but they don't have the same priming. That's what we call that first stage. They don't get the same signals. And some parts of the immune system are unique to mucosal surfaces, to the lungs and your airways. And you wouldn't have some of those induced at all. One antibody that's made is called IgA, and that is specifically a mucosal antibody. You would get very little IgA produced by an injection into your deltoid muscle. So that's why people are doing research on vaccines that are inhaled, that are live, what they call live attenuated vaccines. People are doing research with those type of experimental vaccines, trying to enhance the memory response. And I always use that as an example, and I can, show people papers where people are doing these type of experiments. I would say, why bother? Why are those immunologists bothering to do those if these
ones in the muscle were good enough?
Are perfect? Yeah, right. Yeah. So these claims that vaccine-induced immunity is better than natural immunity doesn't really hold water based on how researchers are conducting research right now. So
yeah. If it was that good, then they wouldn't be looking for the next step, Right. Yeah. Hey, is that I assume then there's going to be differences between that and then something such as the oral polio vaccine, because that's I think a live attenuated vaccine, if I'm not mistaken, and I believe that one they're looking for the immune response to be created more so by going through the body orally rather than into the airways, right? So probably
so that's in the gut, right? But it's
yeah.
You're also talking about a mucosal surface. It's just a different. The gut is also mucosal tissue, so you have very unique immune responses there as well. and it is much more targeted and longer lasting with an oral polio vaccine. I stopped using that because some individuals will, a very, very small number, will have reversion to polio disease. And when you have in Western countries such a low incidence of polio, it no longer is worth the risk because it's enough to do the inactivated vaccine. And it, so over time they switched to the inactivated polio vaccine, basically for that reason, because then it started to make a difference. We're talking about very, very low numbers here of people getting polio versus getting a revert polio from the oral vaccine.
Okay, interesting. But then coming back to the mRNA spike protein vaccines, then this is something that I've read a fair chunk on, as to why there was such a massive leak, shall we say, between the rollout of the vaccine and then the amount of people who were vaccinated acquiring a Delta or Omicron infection. And a lot of what I read lent towards the idea that the initial vaccine was based on the spike protein of the alpha variant. One, is there something to be made there? And two, is this leaning back towards what you were saying about the induced response versus the whole virus when it goes in through the airways versus the induced response through it being injected into muscle tissue?
Yeah, so I think the vaccines will, and I mean, these are things that are sort of fluid, and it's hard to be 100% certain, because this is kind of research that's coming out
It's developing. Yeah.
daily. Yeah, it's a developing situation. But what it looks like is that these vaccines will protect against severe disease for most people, even if they get Omicron. But they may protect against infection less and transmission less than they would from the earlier variants. That is how it appears to me at this time. So you can get a lot of individuals who are vaccinated who are infected. They still have some protection from their T cell response, maybe less so from their antibodies. So that's gonna happen. I mean, this virus is always going to mutate, and luckily this last variant seems to be milder no matter who's infected, no matter what their vaccination status is. Obviously, with the huge numbers of people that are infected, there's still going to be a portion of those who get severe disease, and that's going to be the case as long as you got a large number of people being infected in a small period of time, which is what we saw, especially here in the States with Omicron.
Okay. And I suppose that's what you said earlier as well. If you're going to have 1 billion people infected, there's going to be a lot of differences in the response. And that goes to also whether or not they're vaccinated. There are going to be differences in the response that people are going to be able to mount up, shall we say, from their own immune systems. And what you mentioned there, in that, as it stands with this new variant, it seems to be a little less virulent, which, fingers crossed, things keep going that way. What is going to be the long-term role of this vaccine, do you think, from an immunology standpoint? Are we going to have to keep rolling out boosters every few months or something like that?
In a way, that's kind of a political question. I mean, in an ideal world, I would think in an ideal world that people who have been identified as vulnerable would continue to be boosted. But kids and people who are not in vulnerable populations would just basically live with the virus. I don't make those rules. So it's going to be different. And I guess the encouraging thing is that it's going to be different in every country. And depending on where you live, that's a good or bad thing. Also depending on your views. But the data that's collected from all this is really going to tell us how effective that specific requirements were in each country. Will give us some information. And just like with non-pharmaceutical interventions, which have been widely adopted or not, we have a lot of information about differences those effects had in different countries, in different states, different provinces, cities, and sometimes, even across the river and, very close by. So it's going to be a long time to sort of assimilate all that data, but I think that would be a really interesting thing to keep looking at.
Yeah, it's interesting you bring up the MPIs and non-pharmaceutical interventions. There was that, I think it was the paper from Johns Hopkins that came out recently that showed that on the whole, the utilization of lockdowns had a 0.2% difference or something like that. Have you come across that yet yourself? Or?
I haven't looked closely at that one. I have seen it, and I'm not surprised by that number. Yeah, I mean, based on my understanding before when this first started, there was never a belief that a respiratory virus pandemic could be stopped in its tracks and could only be sort of endured in sort of the least painful way possible, and with a lot of warnings not to cause collateral damage or continue unsustainable.
Because that's one of the things.
Mitigation strategies.
Yeah, those collateral damages that we're now seeing or have felt, whether that be supply chain issues, whether that be economically, or if that's to do with the mental health crisis that was already pretty rough going prior to 2019, but has only gotten worse. I was speaking to a CCU nurse also on the podcast, and she said in her ICUs and CCUs, they had at times more people who were there for attempted suicide than they had COVID patients at times. The domestic abuse rates that have gone up, the unfortunate effect that this has had on children and on education, and for unfortunately some people from less economically advantageous backgrounds, it's also had a massive effect for them as well, where school was a good place for them to be. Can you maybe speak to us a little bit from your knowledge, from everything that you study, everything that you've learned, everything that you've done over the years, as to where these non-pharmaceutical interventions may have even had a place, or if it was just a load of old rubbish that we were all sold because someone else did it, or in this instance, China did it first and said that it worked, so the other governments implemented it. Because to my knowledge, from what I've read, at least for the UK, the lockdown was never an intervention prior to this that they'd ever written in any of their pandemic planning strategies. And they have these strategies. These are things that governments have mapped out. But enough from me. People are here to hear you.
No, yeah, you're hitting on it, and so it might have been 2020. I don't remember exactly when it was, but Jeffrey Tucker wrote an article, and he's the Brownstone Institute founder, and they repost a lot of my articles from my Substack. He wrote an article, and I think this is the first time I actually noticed his writing, but he wrote an article about how basically leaders around the world sort of copied each other with lockdown, and it spread almost like a virus itself. I mean, they saw they didn't want to be the last one left out, and there was just the spread where while everyone's doing it, and it kind of starts almost like a like a riot or something. The first person to
Throw the
grab a
first
rock
stone. Yeah.
and break the window, their threshold is a certain level, and the next person might have a higher threshold, but there's already somebody that's done it. Malcolm Gladwell talks about this with the with rioting, and so I think with any sort of peer group, everybody was watching what everybody else was doing, and there were a few that basically said, all right, we're going to do this because there's no downside. Obviously, they ignored what downside there might be, but we cannot, and I think Fauci said this, it is much better if we get criticized for overreacting. And at some point, that was what the message became, even though the very early stages, the message was very measured, at least in the United States. It was, we don't want to get ahead of ourselves. We don't want to assume it's going to be the worst case scenario. The same folks that were saying these things that made a lot of sense, asymptomatic people don't drive pandemic transmission, all of that stuff made total sense at the time. And then there was a switch where everyone started to not care about those things and, be part of the panic and instead of the solution for it. The leaders were the same. They were afraid too, and not just for their safety, but for their positions and their reputation. And I think it just spread like that without any consideration of, well, if we're going to get blamed, we're all going to get blamed for overreacting. And I can always say, well, this is what WHO recommended, or this is what CDC recommended, or this is what this other government did. I guess in the end, we can probably all blame China, but, there's the people who stood up to this are the ones who really should be rewarded in the end. I don't know how long that will take.
Yeah, might be a while. It's not that I was trying to blame China, not at all. Each individual government made their decisions on how to or how not to approach this. If you look at the Swedish government, they went in the complete opposite direction and let everything just run roughshod, go on life as normal. Mexico had about as much as the same as Sweden in terms of not shutting things down and going for other routes to try to face this. So it became an unfortunate experiment in its own right. I think when you compare the numbers from place to place, and I think anyone listening might then talk about the population density in Sweden versus the population density in somewhere in the US or the UK. But if you break that down further and say, all right, we won't take the whole country, let's go for a comparative city, the numbers are the same either which way you want to go about it over time.
Yeah.
So,
and of course, originally the UK had a Swedish-like response.
Yeah.
And they got
throttled for it.
Throttled, yeah, right.
Yeah.
I mean, I don't know if it was because Boris Johnson got severe COVID and that just, doomed everyone else, but it totally changed. Whereas here, it was more, we got a lot of mixed signals. In the UK, you got a lot of strong signal one way and then completely strong signal
took a
the other way.
Strong left turn. Yeah. But then with that said, one of the other things that was and is still used, thankfully lockdowns are being scaled back in a massive way, but masks are still a very hotly debated topic and dare I say it, with very little evidence to show effectiveness. Can you maybe talk to us a little bit about that, and maybe a little bit about the evidence surrounding it? And then maybe we can talk about the psychological aspects briefly too. But yeah.
Yeah, I was really surprised at what happened. I had not a lot of experience doing mask research. I was in the health effects laboratory division with the people that do those types of studies. In fact, the double mask study that CDC liked to cite, that was done in the old division that I used to work in. So
Interesting.
I know the authors of that. And when you look at that paper, it's funny because they say something like they use mannequins, and they have like a interesting model where the mannequins sort of coughing, and they put the mask over it, and they put two of them, obviously, and then they measured particles that whether they could get through the mask or not. And it's interesting, if you look at the discussion of that, they say something to the effect of how this is not something you can generalize to real world usage. You know, it's just a model. It hasn't been validated in the way that we can immediately say, you know, this translates into the real world. That's exactly what they should have said, you know, but the CDC, when they would talk about that, they obviously would completely ignore that part of a paper from within their own organization. So that's kind of a you know, microcosm of how they have dealt with everything. And I think it's a combination of things, but you know, I blame the fact that we've become this safety obsessed culture, and demonstrating that you're concerned about safety is just this sort of high virtue that has sort of only increased. And it's even to the point where if something big happens, like a disaster, like the pandemic, then people want safety so much to the point where you have to give them more of an illusion than any sort of real steps that they could take to keep themselves safe. Because in reality, this was a natural disaster, and people were trying to treat it like a war, which I think is a terrible analogy. This is something that we have to endure, and not something we can fight. You know, there's no real enemy here. There's no bombers over London. This is strands of mRNA surrounded by a protein. You know, and it's very good at doing what it does. And the masks, I think, were a psychological offering that leaders could offer to people to help them feel safe. I mean, after you shut things down and you convince people the only way you can save lives is to never go out again, you're going to have to convince them at some point that they should go out again and try to begin to resume some semblance of a normal life. But so in some cases, you've really been successful in that message, right? And you have to give them some intermediate. And so I think the masks were maybe a psychological way to do that, to give that safety blanket almost to people. And then, of course, some folks believed it, and some folks took it so far that it became this, you know, overriding symbol of caring for others, you know, taking the pandemic seriously.
It comes back to
And
that virtue signaling that you mentioned not 2 minutes ago. It becomes something for them to champion as a signal of how virtuous they are, right?
absolutely, but you know, the real interest is, for me, is how it's so different in different places. I mean, there's different cultural, you know, obviously aversions to masks in Scandinavian countries, and they put a value on communication between teachers and students. And you know, here the safety or at least the appearance of safety, completely overrides that. We're not considering what the evidence is for children and having it actually make them safer or actually improve their overall health, which is another thing has been ignored. So education is secondary to these things, and that's been a real tragedy, one that I've tried to fight.
Yeah, yeah. And I was just going to say, now that you've mentioned that, the effect that it's had on children, can you maybe talk to us a little bit about these studies that sort of insinuated that the student body essentially were continuing to drive the pandemic, and that they were a big risk also for teachers and whatnot? And in actuality, when I'll let you explain that. There's a very interesting piece in one of the Substacks you wrote on it. So maybe if you can expand a little bit for the audience on that.
The one that stands out most for me was the study from South Korea.
Yeah, that's the one.
That concluded that children were equal to adults in transmission of the virus. But it really had poor methodology and didn't actually, with their contact tracing, couldn't identify who the index cases were. And so they couldn't actually make that conclusion based on their data. But it was widely reported, at least here in the United States. The New York Times had a big article on that right about the time that schools here were trying to determine whether they were going to open with in-person education or with remote learning. And I think that article had a huge influence on
decisions that were made.
Schools going remote in the fall of 2020. And there was a correction article a month later, after these decisions had been made, basically explaining that, this wasn't necessarily the case because we can't determine who the index cases were, if kids were actually spreading it or not. And there was an interesting line in that story about how, well, this is a good lesson to show that you can't take the results of one study and blow it out of proportion, which is exactly what they did and what everybody did. And I really, it was interesting just being on social media and talking to teachers and people involved with the schools, how they really, it's like they wanted that to be true. And there was any sort of argument that, this isn't a well done study. There's other evidence that children are not major super spreaders like we think they are. And I think with influenza, it's not 100% thought that kids drive that either. There's some people that do think that, but at least in the book, The Great Influenza by John Barry, I don't know if you've read that, but he makes a case for that being kind of misunderstood, a myth that kids drive influenza in being in school. So I think it's just assumed based on your experience, as anyone's experience as a parent when they have kids in daycare or whatever, and they're sick for months after that, they just assume that kids are going to be major spreaders. And it turned out that there was never really strong evidence for it, but people were really looking for it. And it was just really perplexing to me that when you're, I think, in a panic stage, that you're really looking to validate that panic. And it's very difficult to encounter someone and not fight back against that cognitive dissonance that you have. because I was trying to give people, like, you don't know this. I mean, this is not something that we're seeing. Someone that I know said, she's familiar with, she goes to Paris, frequently. Said, well, let's just, see what's going on in schools in Europe first, and then we can make the decision what to do, because some of them are keeping their schools open, and see what's happening there, and then we can determine what to do for our schools. And then later on, I'd hear no discussion of that. It's like, actually, we do have that data now, and it's not bad in the places that stayed open. And but
Promising.
people here were very there was a real lack of curiosity to what was going on in other countries. I mean, for such a worldwide event, you think everyone would want to know, okay, how is it being handled in different places, and how are they getting along? I mean, and that data was there. It's not necessarily accurate everywhere, but with that sort of caveat in mind, people should have really paid attention, and they didn't, and that was really surprising to me.
I think for myself, it's become less surprising as I've seen people's responses to this, in the sense that people are quite happy to be told what to do and have the thinking done for them, so that they don't have to, especially in something like the pandemic that we've had, if they don't have to make the decision, whether it goes right or wrong, they feel like they've got no blame in it. And that's kind of just the way the cookie crumbled. So, oopsie daisy. Whereas if there was a little bit more thought for, people thinking for themselves, there would be more onus to take responsibility for when things did eventually go wrong, or when we saw suicide rates popping up through the roof, or attempted suicide rates, or domestic abuse cases going up, or child development suffering massively, especially through the use of masking. If you think of a child who is now 4 years old or 6 years old, they've spent a lot of their early development only being able to look at part of someone's face in order to get an idea of what's going on. I don't know about you, but for me, in my work, it's very important to know how someone's reacting to what I'm saying, if I'm going in a direction that is going to be useful, if I'm throwing them off completely, or what have you. And there are all these elements that, because somebody else outside of the individual made that decision, okay, we're just going to accept it.
And that's essentially applying what I said about world leaders to the average person, right? I mean, it started with the leaders, and everybody was like, okay, we're going to do it this way. Everybody says it's going to work. We're going to assume that it's all going to work, assume that it is working. Anybody that says contrary, we're going to shout them down, and or at least ignore them. And I think that's exactly what happened. I have done the most that I can to sort of undo some of how my kids have been treated in school. I have a 6-year-old, so they understand a little bit about how this has happened, and I told them over and over. I said, we're doing this not because the virus can hurt you, because it doesn't hurt little kids as much as it does older people who are already sick. And I said, we're doing this because people are afraid. And I think they really understand this. But in terms of communication, I mean, they know it's awful for them, and they complain about it. And a lot of people complain about it. Yet I go to some of these meetings and I hear, well, the kids really don't mind. They're doing really well, so, I mean, the folks that made these decisions, it's going to be hard to convince them that this was not a good thing, because they want that validated, I mean, and at the time, everyone was saying it was a good thing. There was no downside, no trade-offs. And, having to face that later on, pun intended, is it's going to be hard for them. And I realize some people, are affected more by it. Some people it didn't bother at all. I happen to read lips more than I realized, but then when people are wearing masks, I'm like, I don't know what you're saying. I mean, my hearing is okay, but it's not perfect. And I really follow people's lips, and I realize that when I'm in heavily masked areas. So for a child that's developing, it's just got to be
Same.
incredibly terrible. And,
Yeah, and
we need to acknowledge that.
100%. Yeah. Actually, there's something that you mentioned there with regards to when you're explaining it to your children, that for them, this virus poses very little threat, if any. The amount of children that have died as a result of this is absolutely minuscule in comparison to the older population. It almost bears on not even comparing it. And of the ones that have, this might be a little bit upsetting to hear. The ones that have, the majority of those have also been quite severely ill beforehand or had multiple comorbidities. So generally speaking, children are almost virtually zero risk, virtually zero. It's not absolute zero, but as close as we're going to get comfortably.
A healthy child dying from COVID is almost unheard of. And if somebody says that a healthy child died, I keep thinking, well, you just didn't know what was wrong. I mean, something undiagnosed.
Yeah. And then that kind of brings me on to, why has this become something where it is something to worry about for the older population? Does immunosenescence play a role in this? Or, yeah, what is it that's going on there?
Yeah, no, that's a very good question. Yeah, I think that has to be part of it. We can't develop we kind of rely on a pool of cells as we get older, memory cells from different types of infections, because you get new T cells from your thymus. That thymus shrinks over time. It's actually replaced by fat tissue, and starts shrinking when you're 10. It shrinks the rest of your life. And so you rely more and more on the pool of cells that are already there, that have been activated by other pathogens, other viruses and bacteria and so on. And so it's possible in some individuals that they don't have that. If we're going with the fully on environmental cause of who gets sick, yeah, it's are you sick with something else that's limiting your ability to have an immune response that's going to be effective? Or are some of the previous immune responses you've had made it so that the response to this particular virus not going to be effective or is going to be damaging? And I think that's something that's really interesting will be interesting to study in the next few years.
Absolutely. I suppose then that kind of brings me on to, when you look at the average age of people that have died compared to the average life expectancy, those numbers are quite close. I think in the UK data, the last time I looked at it, average age of death was 83, and average life expectancy in the UK is 82. It's pretty phenomenal, that. And to anyone listening, that's not to say that younger people haven't died. Unfortunately, that has happened. It has. There's no two ways about that. But on average, the people that are most affected are the people that are almost out the door, so to speak. Is there anything that we can take away from that in order to start returning back to normal, do you think?
Yeah, I mean, I don't know if I'm interpreting your question correctly, but I think about how, you know, elderly people, in the United States, they're in long-term care facilities. Um, I think it's an interesting problem having all of those folks there in one location. And because there are at some point, some states in the United States had 80% of their deaths were in these long-term care facilities. So it was really a problem that was targeted to those types of places, yet the response was so untargeted, unfocused. Um, and so how in a future situation, to keep those vulnerable people safe, I think it's a really interesting question. Um, and keep their quality of living. Because my parents are in assisted living now in the Midwest in the United States. They both got COVID. It was very mild for them, luckily. But up to that point, they felt like they were imprisoned.
Mm.
And, it's a big challenge. It's not something that we could solve. But certainly that would be the thing in retrospect to kind of investigate is how do you protect those folks, and how do you do it in a way where you're not lowering their quality of life?
Not imprisoning them, essentially. Well, while we're still on the, I suppose, topic of older people, maybe not the elderly, but you mentioned there that as we get older, we rely more on this pool of prior infections. Um, ah, um, just quickly then, what about cross immunity? As there has been some evidence to show that people who were affected by the coronavirus from 2003, 2004 have been able to show some moderate levels of immunity against what we have now.
Yeah, no, I was always found that really fascinating. And I think that's contributed to why a lot of people have mild infections, and maybe even why some older people who have comorbidities still have mild infections, is because they have some protection from previous coronavirus infections, or at least something that overlaps in a way that helps them
Okay.
not develop severe disease. But at the same time, it doesn't necessarily prevent them from getting the infection or giving it to someone else, much like we're seeing, with the vaccine.
With the vaccine situation. Um, Last question then, what would be your advice to anyone from an immunological standpoint? What would be your piece of advice for people in order to get back into the world of the living, should we say?
Be as healthy as you can, and don't be a paranoid germaphobe, because it doesn't. It's not worth it. It's very damaging if you carry that fear with you um, indefinitely. You got to let go.
There's also that element of, if you don't have any bacteria or germs around you, then your body has nothing to essentially prepare its response for, right?
Yeah, and I mean that's even possible with mild viral infections. We don't want to get rid of those. Those are part of the way that you develop your immune system and train it to attack things that may come down the pike much later that could be worse. So you don't want to avoid those either necessarily.
No, it's almost like your immune system is a muscle in a way that you do need to train it.
Absolutely.
Yeah. Well, Dr. Templeton, really appreciate your time. And yeah, hopefully for the listeners, there's been some valuable information there, or at least some insight into a different way of looking at the issues at hand. Thank you very much. Enjoy the rest of your day.